Good morning, everybody. On today, we're going to talk about evidence-based practice in nursing. This is something that we as nurses do every day in order to take care of our patients. So the things that we're going to be covering in this chapter, we're going to define what evidence-based practice is. We're going to understand the importance of it. We're going to identify the steps. We're going to explore the process of research utilization. For those that's going to go back and get your bachelor's degree, that is very important because we in nursing, we do evidence-based practice. Either you do it subconsciously or you're doing it consciously. Just know that everything we do in our practice, there has been evidence behind it to state we do and why we do what we do. So, what is evidence-based? Evidence-based practice is a problem-solving approach to the clinical practice that integrates the system in the search for critical appraisal of most relevant evidence to answer a burning clinical question. So if we have something that's going on with our patient and we want to know if we're doing it correctly or if we're doing it right, we want to make sure that we understand what we're doing. So if there's a question that can be posed where we can make our lives better in nursing, then we're going to do it and we're going to find the evidence behind it that states that we can do it. It's a need for change. So I'm going to give you guys an example. Something that we were working on when I was on Evidence-Based Practice Council at Baptist was we wanted to stop the IV insertion of our patients, changing the IVs out every 4 hours, and just change the dressing. Because evidence-based practice states the more puncture wounds that you have in a patient, the more prompt they are going to have an infection. And that is true when you look at your patients that are diabetic. They have a hard time healing. So if we're constantly sticking on them and they're having a hard time healing for those wounds, we're having an opening in their skin that's going to, cause problems with infections. Well, UMC, they utilize that. So the only thing that we do with our patient, if the IV is functioning and it is working, we just clean it up on that site. We put a new dressing on it every 4 days versus resticking the patient. However, at Baptist, that is something that we still do. They haven't gotten quite on board with that because they still want more evidence to prove to say that the patient won't get sick without us constantly inserting the needle in and out. So at Baptist, we still have to start the IV every 4 days versus at UMC every 4 days, as long as the IV is palpable, where we can flush it and we can get good with blood return. As long as we can still use it, we just change the dressing on it. Okay. So it kind of depends on real life situation, which that is a real life situation because most patients don't want to be stuck on all the time. So that was the burning desire question that we came up with when I was working at Baptist, and we had a lot of upper administration nurses that did not want to be on board with that. They feel like, no, the old way is the best way. Just take the needle out and restick every 4 days, regardless if we're getting good blood return or not, unless the patient refuses. And if the patient refuses, the only thing we do is document, stating that the patient states that the IV is working fine. We do not want to get restuck again, and we just document accordingly. So you got to have support behind anything you do. So with that being said, where we want to get our information from? From our scholarly journals. So you have different sites that you can go to look up scholarly journals, and that is something I want you guys to use. Now, Google Scholar is good. However, you have to make sure that you're getting the information that's on Google Scholar from reputable journals. Nothing that's overseas, nothing that somebody made up out of the wind. So you want to use good nursing journals like Nursing Today. PubHub is another one that you can use to get your stuff on. Use just like a lot of different sites, and I will link those different sites in the module or where you guys can go to find an evidence-based article. That's going to be a part of your assignment that you're interested in to see if there's an article on it. And I want you to read that article, cite that article, and kind of like tell me what's the importance behind the practice they've done that you want to see to improve in the nursing profession. All right. All right, so evidence-based is an approach to clinical decisions. We make clinical decisions every day. If I know that my patient has a hard time using the bathroom, for example, and the doctors, they want us to do the bladder scan because they feel like if a Foley catheter is in for a long period of time, longer than 30 days, they're more prompt to a UTI. And yes, that is true if proper hygiene is not done to that Foley catheter. However, my patient is going to be more susceptible of getting a UTI if I continue to do it in and out. If you're not familiar with what an in and out is, you probably want to go through your ATI modules and do that. But an in and out catheter means that the patient is put on bladder protocol, and at the facility, they may say if the patient has greater than 300 in their bladder, then we're going to in and out. And all you do is use the in and out catheter. You do it the same way, sterility. stick the Foley catheter in, drain the bladder, document, and then the cycle goes on again, and we normally bladder scan them every 6 hours. Now, that can irritate the meatus a lot, especially in our females because of the anatomy of the female. But it's different than the male. The male is right there. The female anatomy depends on the age. It's going to be a little bit different. So with that being said, they're going to be more prone to have an infection, and evidence-based practice says that if you have to in and out your catheter patient more than twice, you need to go ahead and just do a regular Foley catheter and make sure that they continue with good hygiene. But that is something that a lot of hospitals frown upon, depends on your policy and procedures of your facility. And remember, you have to advocate for your patient. And when you're advocating for your patient, you got to make sure that you have the evidence to back up what you're stating. So evidence-based practice in nursing. This requires us, the nurses, to critically think, critically know how to use and do the research basis, utilizing those sites, make sure we're using replicable information, making sure there's scientific knowledge that's behind what we're doing. And 9 times out of 10, it's going to be the nurses that's writing these journals that's been in practice for a really long time and want to make the best out of our patient care and outcomes. Remember, I told you guys when we had lecture in mental health that we are the backbone of nursing. We see everything, we analyze everything, and we help the doctors. We are there together to collaborate as a team. But we see more, and we want to make the outcomes be a little bit better for our patients. So with that being said, we as nurses, we're going to read, we're going to get our evidence, and we're going to present it to the physician. Because remember, it's the patient that we want to make safe at all times. It's all about patient safety, the acuity of the patient, making sure they don't have any kind of infections, make sure that they're able to go home with the correct knowledge to be able to take care of themselves, to keep them out of the hospital. That is our main goal, to get them well, keep them at the hospital, because discharge starts on admission. So everything that relies on the patient is based on our practices as nurses. The doctors just write out the prescription of whatever they think is going on with the patient. However, we as nurses, we treat the patient as a whole. So when you're doing your objectives, you got to make sure that whatever evidence you come up with, it has to be strong evidence behind it. So it means that they have to have a peer review. That is something that you all are going to learn about a little bit later. So when you're looking at your journals, you want to see how many people are behind that review. So if you look on page 584, you have your different levels of systematic review. This is going to be like your evidence base. So you have level 1. This is going to be your systematic review, meta-analysis. Then you have your level 2, which is your randomized controlled trial. Level 3, level 4, level 5, and level 6 and on forth, okay? So your lowest level is going to be your lowest level 7, and that's going to be just based off their opinion. So do I want something to be based off of opinion of somebody, like John Blow said, oh, well, this worked with mama, so I think it's going to work with somebody else. No, you don't. Normally in practice, on a master's and on a DMT level, they want you to try to stick between level 1 and level 2. Level 3, bare minimum, least amount of articles that you want, but they want strong articles to back your evidence. Like I'm working on my well, not so much dissertation, but I'm working on my project, which I got it approved, and I'm trying to get it published or whatever. But mine is just basic bedside rounding. If you take care of your patient at the bedside and make sure everything is done, that's going to prompt other things not to happen, such as missed labs, misdiagnosis. If your patient going to surgery, make sure they have on the right armbands and that they need to make sure that you don't cause any congenital events. That's just basic. And a lot of nurses, they get away from just basic bedside nursing. Basic bedside nursing is the safest way to take care of our patients. So I found a lot of strong evidence that states that bedside rounding is the safest thing for our patient. I came up with like over 30 plus articles and within the last couple of years. Now, last year when I was working on my other paper, I was talking about ADHD and red dye. And some of you all know, if you follow the news, they're trying to cut red dye out of some of our diets, such as the things, because it heightens the things in our babies that have ADHD and non-ADHD. So I did my correlation on that in my paper. Missed about like a point or two to get it published, but my instructor is trying to send it back through JBI to get it published, especially now since more research is done. It's stating that it is the red and the blue and the yellow dye that is causing the inactivity in these babies with ADHD, and it's causing problems with their medication because remember we talked about the receptors and the transmitters. It's causing issue where the medication cannot attach to those receptors and those synapses to make the child better. So she emailed me about a couple of days ago and said she want to try to resubmit my publication through JBI to see if I can try to get it published now since more evidence has come about. So that is something that's very exciting. And so when I was working on that particular one, all of my articles were between level 1 and level 2. And this is something they have been working on since like the mid 70s and 80s, but nothing was done with it because you got to look at it. We buy food all the time, and that's going to be hurting the people that are making our products like our drinks and our foods with the dye in it. That's going to cut the middleman out, and they're not going to have a job. So, of course, research was dropped, but we're looking at the betterment of our patient. Do we really want these babies to be on these stimulants? And we kind of like talked about that with the stimulants and with bipolar and all those things if it's genetically linked. So those are the things that also that was attached to my paper because it stated that those babies ended up did have a second diagnosis of bipolar, and then of course we know the medications that they have to be on. We got a problem because if they are already heightened, we can't really have them on a stimulant. So we got to try to fix the diet. Okay, so that's one of the things you got to make sure that you have strong evidence. So when you all pick an article for this homework assignment, I want you to pick an article that have a level 1, level 2. When you're looking at your book, so it kind of like tell you the type of trials, how many people was in the trials. Now, I don't want you to find an article where they only had like 10 people in the trial. That's not strong evidence, regardless if it's a systematic review. You want it to be over 30 plus people that's in this trial and what it did. So make sure that you're digging down on your good evidence, and this assignment is going to be needed to be submitted by Sunday at midnight, because this is something I'm trying to help you guys learn how to start researching, because this is going to be very important for those who want to go back and get your bachelor's. All right, so the history of evidence-based nursing all started, and it was introduced by a project in the late 70s. They would be research of a common nursing procedure, and they mostly was focused on a patient that had decubital ulcers, reducing diarrhea and to feed patients. Now, anybody that have ever gone to clinicals with me that may have had PEG 2, because I do give y'all a PEG 2 patient, you know they're going to always have diarrhea. So what they wanted to do was to reduce the diarrhea in these patients, so they had to try to figure out what's going on. And if you know anything about the gut has good bacteria and bad bacteria. So with that research, they noticed that the bad bacteria was taking over the body, and you have the feeding, which is straight sugar, so bacteria feeds on the sugar, which was leading to the diarrhea. So they had all the evidence based. So now you have the different types of feedings based on the patient's diagnosis, based on the patient's other health histories and things like that. The cubital ulcers, the same thing. We know we need to just turn our patient. It's just common sense every 2 hours. So that's kind of how evidence-based practice got to going by different things to make the acuity of care of our patients better without causing problems. So if I have a patient that's having diarrhea all the time, on the backside, what's going to happen? They're going to end up having skin breakdown because we're constantly wiping it and their bottom is becoming raw. Okay? All right, so the project developed research-based protocols, systematic implementing them into practice. So, of course, whatever we do, we have to do a trial. That's anything. Do a trial. So what they did was, and what some things that we did on our floor, on our unit, when we was trying to cut down on class B's and Claudies, which those are acronyms. I'm not going to tell you what they are. I want you to look them up. Class C, Claudies. All right, and what we were trying to do to prevent those things from happening, those are like infections of the UTI, systematic UTIs, and then you have your Claudies are going to be your central lines infections, which you know I taught y'all central lines and told you how you need to scrub the hub, scrubbing them. So even though nurses were scrubbing the hub on the patient, they still was getting central line infections. And then we have the Curo caps, the little green, orange, blue caps or whatever like that we use. Y'all, when y'all get out of practice and when we go to clinicals, every facility has them now. Make sure your patient have Curo caps on the ends of the lines that are not being in use, because if a patient is in bed and they're constantly turning and twisting and turning, germs get on it. And the first thing most nurses do, they don't scrub the hub like they're supposed to for 15 seconds. They just swipe that alcohol across and then they stick the syringe to it and do whatever they're going to do. And they just flush whatever's in there into that patient. And that's what we start noticing with certain nurses, and then that's when we start doing more education, saying you got to scrub the hub for 15 seconds. So you got to scrub it and you have to let it dry, and then you utilize it. And then we use the Puro cap. So you want to make sure that we do all these things because we want to make sure that we implementing all these things into practice. All right, so the need for evidence base. We want to document and we auditing. So, like I said, when we was trying to cut down on our central line infections and on our CLABSIs and Claudies on our floors with our patients that was having these spontaneous UTIs, we started using chlorhexidine wipes. Some of you all that have gone to clinical with me know what they are. If they have a central line, they have a port, or if they have a Foley, they get wiped. Those lines get wiped down with that because they cut down on the germs. And so when we started using that and we started piloting it in the ICU units first, and they did it for a run of 3 months because you got to have 3 months of data where you started and where you ended to determine if that data was good for practice. And once they did that, they presented it to the unit council, and we made it hospital-wide. So if anybody that has a Foley catheter, central line, PICC line, or anything like that, we utilize those chlorhexidine wipes and wipe them down. We also put it over into our surgery. So surgery decided they want to use it because most people, when they come from the outside to do outpatient surgery, you tell them to take a bath. Some of them use those fragrance soaps from Bath and Body Works. That's not getting the skin clean like they need to. So they start piloting those chlorhexidine wipes into surgery. So what they do when they come to surgery, they wipe the patient completely down wherever they haven't surgery at, and they cut down on outpatient surgery infections as well. So we utilize that evidence base in the hospitals across the board. If your facility that you're working at, if you know you've done preceptorship at some of these other hospitals outside of Baptist, because that's what we use, and outside of UMC, if you've gone to St. Dominic's or Mary Madison and they're not doing that, then you probably want to get with the educator on that floor and say, hey, this is what evidence-based say that we should be doing. Have you ever thought about utilizing that? They may not have, because remember, we want to be universal across the board for every facility because we don't want any of our patients to get sick. All right, evidence-based resources, everything, like I said, it all revolves around the patient. We're going to assess the continuity of care of our patient, making sure the patient is doing what they're supposed to do. Make sure we're doing what we're supposed to do as nurses, make sure that medication management is done properly and corrected. Patient education is always the key. Keep it down hospital infections. That's the main thing because I told you all before, when I've taught y'all in the past, if a patient gets anything while they're in the hospital with us, that cost is on us. It is not on the patient. Those are called hospital-acquired diseases like hospital-acquired pneumonia, hospital-acquired C. diff. Those are things, and people know how to get rid of C. diff. If C. diff is around, we're going to put our patient on isolation. Make sure we're washing our hands with soap and water. Hand sanitizer is not going to do it. So it's like just being educated of the different disease processes and know how we need to go forward to make sure we don't spread those germs around the hospital. Making sure that we document appropriately, make sure that whoever we need to incorporate in this type of care, making sure everybody's involved. And that's include risk management. Sometimes risk management has to get involved to do education too with the floor, especially if we're having the same thing for centennial events. That should not be happening if the nurses are doing what they're supposed to do to keep the quality of care for our patients being the utmost standard. All right, so you have your components of evidence-based, you have your clinical expertise, your best research evidence-based, the patient values, and which all leads into your evidence-based practice. So remember, like I told you guys, when you're looking at evidence-based practice, you want to make sure that you're utilizing the best research, which is going to be your level 1s, level 2. Try to stay away from as many level 3s when you're doing your research because the more peer review that you have behind it, that's going to be stronger evidence that that's something that we need to be doing for our patients. Make sure that the publication is up to date. If it's something, sometimes when you pull those journals, they'll say it's been updated from an excerpt from 1989. That means whoever picked that research up again, they're going to piggyback off of what they learned in 89 to make it better in now. So everything always started with something. You have to have a basis. And if you feel like something needs to be better, then we're going to just insert where the original research started to make it better. And those are going to be your clinical expertise and all those things like that. So all of those things go up on a peer reviews. You should have more than 2 people that's doing a peer review. If it's one person that's doing a peer review, do you honestly think that is a strong peer review? It is not. That's going to be based on somebody's opinion because remember, we got to agree to disagree, and everybody has to agree on different questions. Okay, is this something that's going to benefit your patient or it's going to benefit the hospital more? Remember, Yes, we want to keep the cost down in the hospital, but we really want to keep the cost down with our patients because we got to remember most of our patients are on fixed income and they cannot pay a lot of things, and it's going to be prompting them not getting their medication like they're supposed to, being adherent to the therapy. So we have to follow the evidence-based practice module to make sure that we're doing everything we need to do for our patients and our clients. Clinical expertise, like I said, these are going to be the people that have researched, done the legwork. Like I told you, that's when they go through those clinical trials. Like I gave y'all the example where we started out in the unit, because remember the unit is the smallest one where they're supposed to be 101 at the time with the patient, where the nurse only have 2 patients and that's their 101. So we started off in the unit first, and we did our running trials to get our clinical expertise to be able to move it over to the next unit to make sure they're following the module that the unit did, and to make it hospital wide. So like I said, my module that I'm working on for UMC for mine is to start back with bedside rounding. It's something that this just pretty much went to the bed, the wayside. And if some of you all know, they've gone to clinical, that most people do not go to the bedside to do their reporting. They do it like in a little hub in the nurse's shell, and then they leave. And then when they leave, then guess what? Now Miss Billy down the street, her Foley catheter came out and pees all over the floor. Versus if that nurse would have went in with the night nurse and did the bedside rounding, that was something that could have been caught. Okay, those are called sentinel events. Those are things that should not have happened if they were rounding at the bedside. Best research evidence, like I told you, you want to make sure that you have good peer reviews, and it needs to be more than 2 people on that peer review when you're doing to make the evidence strong. The more people that have reviewed this evidence to put into practice, the better it is. You want to go back when y'all do your research on whatever thing, mind-boggling things you want to like make better in your practice that you've just seen out in practice and clinicals. Use something within the last 5 to 10 years. Do not go any further than 10 years. So if we're sitting in 2025, that means that whatever you're researching should not go past 2015. Really 2020 to be exact, but really 2015. I'm going to give you that. So when you're doing your research on whatever article that you want to do your write-up on, do not let your articles go past 2015, okay? Because remember, we want to stay up to date. We don't want to go back. We want to make sure that everything's kind of built on whatever research that you're researching. Patient values, like I said, they are the center of everything we do when we're doing anything with evidence-based. We're not willy-nilly just randomly thinking of things that we want to do. Everything that we do in evidence-based is always going to be patient-centered. Something happened, we need to make it better, so it's going to be patient-centered. Like I said, the things that we worked on, we had high numbers of CLAPSs and Claudies. When I first started at Baptist, we wanted to get those down. So we came up with ways, and we had the materials at Baptist. We just weren't utilizing them the correct way. Especially when you have your reps that come in and say, hey, we could cut down on this if you do this, if you follow their module, and they're going to bring you the research. They're going to say John Hopkins used this or MD Anderson used this. They're going to have the stats to say that this works. That's just like with chemotherapy. Certain autoimmune therapies like Keytruda and Aldivo for our patients that have lung cancer, there has been studies after studies after studies that say, hey, yeah, they can get chemo, but we throw this immunotherapy in there, this is going to make their life expectancy even longer based off the trials. So they have that. And so then that's when they say, oh, okay, well, let me give my patient more years to live. Let me throw this in here as a maintenance treatment, because that's exactly what it is, maintenance, to give them another more quality of life. So the evidence had to be there in order for us to move forward to make sure our patients have the stability to live long as they can. Okay, so steps to evidence-based. We're going to formulate an answerable clinical question about a patient, problem, or intervention, or outcome. We're going to search it, find the answer. We're going to do the appraisal on it. We're going to apply it, and then we're going to assess to see did it work for our patient. Now, like I told you guys, there is not anything in evidence is not a one-size-fit-all. Everything is different. So, like I said, something that may work for Miss Sally that had a UTI may not work for Miss Billy that had the UTI. Because remember, we treat the patient as a whole. So we have to figure out, does Miss Billy have diabetes, stage 4 cancer, and other comorbidities that's going to cause her clinical outcomes to be a little bit different than my patient over here? So if I want to know if this evidence is going to sustain, then I need to know, did they have anybody in these clinical trials that had diabetes or stage 4, any kind of cancer? So remember, we can't lump everybody in the basket. They have to have different things to make sure that we're doing it. So if I want to make sure that this information is going to work for Miss Billy, that may have stage 4 cancer and diabetes and all this kind of things like that, I need to find clinical articles that state that this also can work for them. Because if not, then it really can't fall suit in that. It only is going to apply to the people that falls up under that criteria. All right. When we think about pain management, we always do the least invasive. Pain management. A lot of people like to throw medication at it. Sometimes it's positioning. If my back is hurting, maybe I need to position in the bed, turn them off their side, get them off their bottom, make them comfortable. Now, granted, I told you guys we do not massage any patient at all because they could put us at risk of having this saying that we're trying to sexual harass our patients, okay? I don't do that. If they say, can you massage my back? Absolutely not. I don't do that. I will give them a heating pad. I will give them a cold compress, but I do not do any of those things to patients that I feel like that's gonna, try to set you up for the okie doke, make it seem like that you're doing something that's unethical. Okay. I'm sorry, that's going into more of your personal areas. I can't do that. But let me offer you this. I can get you a cold compress. I can give you a heat pad. I can give you medication. We can position you. We can get wedges. We can change your bed out and get an air mattress. Those are the things that I'm going to do for the patient. Massages is something I just do not do at all unless it's my family personally, okay? When we do the pain score, we know that we're going to grade them on a scale of 0 to 10, with 10 being worse. And we want to educate them. If their pain level gets over 5, it's going to take longer for the pain to come down. So we make sure that we're educating them. And then once we do our clinical decisions, and then we're going to evaluate. Now, guess what this looks like? This looks like a whole care plan, doesn't it? We want to find what the problem is. We're going to do our interventions. Did our interventions work? Did they meet it? Was it partial? Anything like that. So those care plans that y'all be griping about that y'all really don't want to do, you're really doing evidence-based practice. That's really what you're doing. You're not even knowing that you're doing it. Okay? So that's the purpose of the care planning, because once you make it second nature, then you're going to come up with different things in order to make everything better for our nurses and for the patient. The benefits of evidence-based practice will provide better patient outcomes. That's just the top priority. We want our patients to live longer, stay out the hospital, be able to manage themselves at home, regardless of whatever it is, to the point where they can no longer manage themselves and then they have to come back. We don't want them to keep coming back for the same thing, because believe it or not, with this insurance, if I have a patient that I'm supposed to have gotten out the hospital for a diagnosis of diarrhea, and I've given them the education on what to do, and I've documented my butt off, saying that I told them these are the things they need to do, and then 3 days later they come right back in with diarrhea, do you think that insurance is going to pay their claim? They're not, because they're being admitted for something that we just dismissed them from. So we got to make sure that that patient is ready to go home before we discharge them. Now, granted, most insurance say, okay, we need to have them at the hospital in 4 days. They might not be ready. They may have other issue comorbidities that's coming up that we need to address. And when we do that, then we need to make sure that we're documenting it to make sure that we're not eating the cost as the facility, but making sure that the hospital is getting paid like they're supposed to accordingly based off the insurance, and that the patient does not have any out-of-pocket expenses going forward. Factors that facilitated knowledge: we have mentors, we have skills, our beliefs, and we have to have the tools. Do we have the tools to do what we need to do to take care of our patients? If it's something, like I said, if you know you want to work on cutting down on central line infections, do I have the necessary material and tools to educate my staff to cut that down? If I don't, then I need to be facilitating with somebody to get the things that I need to be able to do that. You want to mentor new nurses. You want to make sure that they're following the policy and procedures of whatever facility they're working at. And most of the time, they're going to get that down in education before they come to the floor. And you as nurses, we need to make sure that whatever they learn in education before they come to the floor, that they continue to do that. Barriers to evidence-based: lack of barrier research and practice, lack of administrative support. If the administrators feel like that's just a waste of time, they're not going to support you. But if you have the research to back, which I said you're going to have level 1, level 2 are going to be your strongest research. If you have that to back that and show them this is what we need to do in order to cut this down, then it's going to cut out the barrier. You got to make sure you have strong evidence, strong research when you're doing this. Even though when I was on Nurse Practice Council, we brought that evidence to them with the long-standing practice of Johns Hopkins. But when you have a higher administration that's been doing it for a long time and they are set in their ways, it's hard to change that. So then you got what do? You got to follow the policy and procedures of your patient, even though you have the strong evidence. But you're going to find a facility that's all about research, and UMC is all about research. It's a research hospital. That's what they do because they want the outcomes to be a little bit better for our patients. So if you know that you're all about research and you want to make those things happen, then you need to find a facility that's going to back you on your research to make sure that you're making everything happen. Continuing your education is very, very important. I don't want you guys to graduate from this program and say, oh, well, I got my RN degree. I don't need to do anything else. You do. Nurses learn every day. Continue to get your education because remember, we want to make our profession better. And the better you make your profession better, you make yourself more marketable in the society, in the community. Later on this month, before you guys graduate, I have a surprise for you that was bestowed upon me, and I'm going to wait until it gets here, and I'm going to show you what you can do and what you can accomplish when you do what you need to do as a nurse, okay? This was a big honor that was bestowed upon me, and I was very honored to do this. So when it comes in, I'm going to let you guys know. Even Dr. Austin and even some of the instructors here don't know that because I wanted to be a surprise to them because I wanted to make sure, and I did represent Holmes Community College well, okay? So when that big surprise come about, I'm going to let you guys know because y'all know I eat, sleep, and breathe nursing, and I love nursing. I love everything about research because I want our profession to be better. I don't want us to be lacking in knowledge. I want us to be able to make our patients better and not be sick. And sometimes the only way we can do that is to research what's good for our patients and what's good for us as nurses. All right, turn daily practice into evidence-based practice. So if I know I got little Billy down the street, and little Billy is always sundowning, okay, he's always sundowning at this time. Let me take him outside and give him some sunshine. Take him out of, you know, that word delirious, because if they're in a room not doing anything, they're delirious. What is something I could do to keep him from sundowning? So when I worked out at State Hospital, but we had a patient that was sundown all the time at 5 o'clock on the dot. So what we did, we started taking that patient outside at 4:50, brought her back in at 5:30. No behavior issues because we got her out of it. We changed her environment. We changed her surroundings. So we took her from the inside of the building, took her on the outside of the building, and we put evidence into practice. So what we started noticing and we start implementing, hey, if your patient is sundowning and if they don't have a behavior issue, take them outside between these times. Change their environment, and they did. And we did that with a lot of our patients, a lot of them, and that helped a lot with the sundowning. So you got to put evidence into practice. And what we did, we started reading articles, and we was like, oh, well, it's saying right here, if they're sundowning and they have this diagnosis, take them outside and let them get, because remember, vitamin D is good for the body, it's good for the brain, it's good for everything. That's going to help with the sundowning, and it really did with these patients. Okay, everybody should know who this is. This is Florence Nightingale. So she never lost sight on things. So I'm not gonna read you the story of Florence Nightingale. That's something that we learn in Nursing One. If you don't know about Florence Nightingale and what she did to cut down on different things, then shame on you. Slap your hands. You read it. I'm not gonna go into it, but just know that the root of everything, she wanted to prevent infections in the soldiers. Okay. All right. So that's what I have with evidence-based practice. Make sure you guys read the pages. Evidence chapter 24 is not long, y'all. It is not long at all. But my main thing that I want you all to do is to find something that you're very passionate about, that you feel like that you want to be a part of to change in our nursing profession. See if there's an article on it. See what the evidence say. And then I want you to cite that article for me. I want a copy of the article because I want you all to drop it in the PDF so I can verify it. And I want your opinion on what they researched and how you can make it better and how you can contribute to that science. If you guys have any questions, put your questions in the drop box in the discussion. That's pretty much our assignment for this week for evidence-based practices. I want you to find something that you're very passionate about, find the research on it, see if there's any research on it, cite the article, give me a synopsis about what you learned from the article and what you feel like that you could do as a nurse in better practice. And I'll see you guys next time.